Okay, good afternoon, good evening, everyone, and welcome to the Shop Ostomy Supplies webinar. Tonight we have Christine Kijek, who is going to be doing a presentation on preparing for an ostomy reversal. So Christine, I'm going to let you're muted now, but I'm going to let you take over. And Christine, can you see my screen?
Yes, I can. Thank you, Heather.
Okay.
All right, so to get started, hopefully you're somebody who's planning for your ostomy reversal. And I'll start by saying that when you end up with an ostomy after an emergent surgery, everyone counts the days until that reversal can be done. So during that post-op recovery period, it's really important that you eat well, walk lots, and regain your strength and get back to your baseline. The reversal surgery is considered elective, and you do want to be in the best possible health to move on to that surgery. This will make your recovery from that reversal surgery much easier than the surgery you had to get that stoma. Next slide. All right, well, I'll continue. Temporary ostomies are usually reversed within 3 to 6 months. This is dependent on the extent of disease, or the type of treatment plan you're undergoing if you have an ostomy because of cancer. So if you're receiving chemotherapy and or radiation, you really need to complete that therapy before you move on to that reversal surgery. If you interrupt that treatment plan as far as chemo and radiation, your good outcome can be reduced. So bowel function after reversal surgery is different, and it depends on which type of stoma you had, and again, how long you've had that stoma. Are you able to advance the slide, Heather?
Christine, I'm trying we're having a little technical difficulty in just a few minutes. If you just keep talking, and then I'll eventually
catch up.
Yeah, we'll catch up.
Okay, so if you have had a Hartmann's procedure, and that typically is a procedure that's done for perforated diverticulitis, it's in the descending colon, so that's on the left side, lower left side. Sometimes it might be a little bit higher up, but optimally lower left. The reversal is done usually laparoscopic, and it's done through that stoma site. Oh, perfect. This is the perfect slide, Heather. Thank you. So the reversal surgery, though, does require a bowel prep to clean the colon out. And typically they'll do maybe a barium contrast CAT scan, where it's basically a contrast enema. They want to check to make sure things are healed okay before you move on. So with that said, again, they go through that stoma site. With the bowel prep, I do recommend that you use a high output pouch. This is one of them. It's got a nice, it's larger than the usual, and it's got a liquid spout. And you would put this pouch on just before you start drinking the bowel prep. There are other pouches available. This is an actual irrigation pouch. It's very long and it attaches to your barrier. You do need 2 pieces for this. And that just will help with that bowel prep while you're cleaning out. So typically after a Hartmann's procedure, initially you may have a little bit more frequent stool, just for a short period of time, and it might be a little bit looser, but the sphincter muscle in the rectum is not affected. So holding on to stool should not be a problem for you. Your new baseline bowel habits usually fall into place after about a month. And with that sigmoid being gone, the sigmoid colon, typically you may have 1 to 2 bowel movements a day. And that's because the sigmoid colon, that portion is works as a storage facility in order to hold a stool before you have a bowel movement. Next slide. All right, if you've had a total proctolectomy, this is where the entire colon is removed, as you can see from the picture. The one on the right is your colon being intact, but the one on the left has no colon, and you usually end up with a ileostomy to start with this. And you may be a candidate for a J pouch or an internal pouch. And there's a couple of pictures there of what they look like. So conditions that usually require a total proctolectomy are things such as chronic ulcerative colitis. If you have familial adenomatous polyposis, that's lots of polyps, runs in families, you're more likely to advance into a cancer. And then there's also a non-hereditary polyposis colorectal cancer syndrome. So those are some of the reasons why entire colons need to be removed. Also, the rectum comes out with that. So that can certainly create a problem with bowel movements after surgery. So this typically is a 2 or 3 step approach. Your first surgery would be the surgery where the colon is removed. The second surgery will be the creation of the J pouch or the K pouch. And again, you can see some pictures here of what they look like. And that opening in the bottom will be attached to the anus. And this needs to heal before we reverse the ileostomy. We want to make sure it's good and sealed prior to that reversal. Now, the expectation after all of this, and you have the reversal, if you have the J pouch or the S pouch, you do have frequent bowel movements a day because you don't have that function of the colon to absorb fluid in the waste. So typically you're having 12 to 15 bowel movements a day initially, but as that pouch stretches, it will, you'll go less often. And so on average, somebody who's had this surgery for about a year, you may go down to 6 to 8 bowel movements a day. Typically, these patients are managed with Imodium, which helps slow down that GI tract. We also offer a script for something called Lamodal that will slow down, and there's a drying agent in that as well, which helps you hold on to that a little bit more longer, hold on to the fluid. And then there's the K pouch. If you have a K pouch, that is not hooked to the rectum. It's an internal reservoir. Next slide, Heather. I think there's a picture of one. There you go. So with the K pouch, again, this picture will show you it's a reservoir inside the abdomen, which you do need to place a catheter into to empty and allow that stool out. And it is liquidy. It's not thick at that point. Next slide. Now, a low anterior resection, as you can see from this picture, it's a little bit beyond the sigmoid colon, and it also takes the rectum. So, or most of the rectum, there's just a small portion there, and of course the anus. So with this type of procedure, we usually see it for cancers that are in the upper portion of the rectum. The sphincter muscles are not affected when they do this, this surgery, but changes after the reversal can really be debilitating. There are usually frequent stools, and there is some urgency. So you can, a lot of people can have some incontinent episodes with that. They can have increased gas and clustered bowel movements. That is when you have multiple bowel movements over a couple of hours, and then you're okay. Some people will have a day of having lots of bowel movements, and then the next day they don't have any. And these symptoms are called low anterior syndrome. And again, it can be so debilitating that some people will go back to the OR and request a permanent colostomy. This way they're not tied to the bathroom. So quality of life does deteriorate with this. Typically, management of these symptoms, if you choose to not have a colostomy, I would recommend Kegel exercises to strengthen those pelvic floor muscles. We do utilize Imodium and Lamodal. Probiotics also help as well, and eating small frequent meals, and you do want to chew that food well. Next slide. All right, so preparing for the surgery. This is a program our hospital uses. It's called Enhanced Recovery, and it's a program that has steps that will optimize your health before you go into surgery. So we do want to make sure you go into surgery with adequate protein levels. We want to optimize your ability to ambulate and walk around because walking after surgery is very important. You do, again, have to do a bowel prep for these. Unless you have an ileostomy, then there is no bowel prep. Typically, if it's a colostomy, there's some antibiotics involved. The antibiotics you would take the evening before surgery, and it's usually when you're doing that bowel prep. That decreases the bacteria in the colon, so it does reduce the risk for infection. We do carb loading with this. So after you do your bowel prep, there's these Ensure pre-surgery drinks. They are clear fluids. There's no protein in this, but they are high in carbohydrates. And those carbs, our bodies break down into simple sugar, and it's stored as energy for our bodies to use the day of surgery when we don't have any of those sugars coming in. This program allows you to have clear fluids up until 3 hours before surgery. So that's your cutoff time. So typically you'll drink 2 Ensure pre-surgeries the evening before surgery after you've completed your bowel prep. Usually they should be consumed by midnight. And then the last Ensure pre-surgery is taken at the 3-hour mark prior to your surgery. That will be the very last thing you drink. This helps with your hydration status. And then these sage wipes, they're chlorhexidine. This is to clean the skin where the surgery is occurring. So we all have bacteria on our skin and we don't want to reduce our risk for infection. So we use 2 packages of these. There's 2 wipes in each package. And one is used the night before, after showering. And the second one is used the morning of surgery before you get dressed to head to the hospital. Next slide. Now, in this enhanced recovery, we call it ERAS for short. Part of this program is to minimize narcotic pain meds. Narcotics do slow down the GI tract and they can cause constipation. So we try to avoid using them. There's lots of different modalities to help with pain. We use IV Tylenol, Toradol, which is an IV NSAID. It's better than Advil. They will give you Celebrex. Sometimes they'll give you Celebrex prior to surgery. That is anti-inflammatory. When you get advanced into tolerating food, they may give you some muscle relaxer type medications. And a medication that's used on nerve-related pain. This program does stipulate we want early ambulation, and that means getting up and out of bed the evening of surgery. If you're not able to do a lot of walking, at least sitting up in a chair that first night, that movement in and of itself helps tremendously with getting things stimulated and reducing your risk for complications after surgery. We also use the premise that early PO intake, sipping fluids, sipping a high protein drink after surgery helps to stimulate the bowel to function normally. So typically you'll get ice chips after you get to the surgical floor where you're going to spend your immediate post-op recovery. They'll start you with ice chips in the morning. They will typically give you a clear liquid diet. And if you do fine with that, they'll advance you to soft solid food for lunch. All of these steps will decrease your length of stay. That means we do see patients with ostomy reversals going home post-op day 2 late in the day. And if you're not quite ready, post-op day 3 is fine. There are certain goals you do need to reach in order to be discharged from the hospital. And those include tolerating food. You need to be passing gas. You need to be up and about and walking independently, and your pain needs to be controlled by oral medication. Next slide. So changes in bowel function after the reversal. If you've had an ileostomy, usually the colon, because it hasn't been functioning for a while, there's some slow absorption of the fluids. So you tend to have some loose bowel movements, and you will also have some urgency with that. So be prepared. It's a good idea to have, maybe some incontinent pads or some Depends around. just to get you through the first week or two. It does get better. Your colon will get used to having that stool flowing through it again. And so it just takes an adjustment period. Now, depending also on the part of your colon that was removed during surgery, if you've had the right colectomy, that's the right side of the colon, the function of that portion of the colon is to absorb fluid in the waste. So if that part is removed, then I would expect you to have looser bowel movements. The rest of your colon will eventually, over the course of the next couple of months, pick up that slack and absorb more of the fluid. But we may need to initially give you higher fiber and a motility agent such as Imodium. The transverse colon, and that's the part that goes across from right to left in the upper portion. The function of that is also for fluid absorption. So if that portion is removed, then you're going to have a little bit of looser stool initially. And then on the left side, if you have the left side of your colon removed, the upper portion is responsible for some fluid absorption and some mucus secretion. And then when you get closer to the sigmoid colon, which is that curved piece right before the rectum, that acts as a storage facility. And the function of that is mucus secretion. So with that said, that I would expect you to have some formed stool when you have this reversal. Next slide. So again, with the reversal surgeries, your anal sphincter is not affected. However, because you haven't used it in a few months, it may not be toned. So it's a good idea to start Kegel exercises. If you're newly out from surgery and you've not had a low anterior resection or anything affecting the rectum, you can continue to do Kegel exercises just to keep those pelvic muscles strong. If you've had a surgery that affects the rectum, then I would suggest you wait until you're 2 months out and start your Kegel exercises about a month before you're going to have that reversal. Early diet or diets with the looser stools, I do recommend that you continue with those foods that tend to thicken the stool. And that's going to be things like your starches, your pasta, rice, potatoes, and bread, banana, cheeses, yogurts, boiled milk, pretzels, tapioca. And again, we still will continue some of those anti-diarrheal medications like Imodium and Lomotil. Usually when you're about 2 weeks out from surgery, we start adding fiber to the diet. So that will help thicken things for you to make it a bit easier. Next slide. So to finish, I would like to say that there's a lot of factors that play a role in your recovery from surgery. Being in your best state of health for that elective ostomy reversal surgery is so important to your overall health. And you are the biggest key to success. And we, as healthcare providers, are here to assist you in getting better. Stay well. Thank you. Heather, do we have any questions?
I'm just looking right now, Christine, and I actually am seeing none. There are 14 participants, which is wonderful. If anyone has any additional questions, you are welcome to type them into the Q&A section in the Zoom, and I will read them. They'll be anonymous, and we'll just read them and get them answered for you. So I'll just take a few minutes to let people, if they do have questions, go ahead and plug away.
So, and I will say, I know we're talking about preparing for reversal surgery. There are some of us out there who look forward to not being reversed because their quality of life does get better once they have an ostomy. Of course, that depends on what your health issues are having the ostomy surgery. But I, for one, am happy to have mine. So I'm not looking forward to a reversal.
Okay, we do have one question so far. Is the surgery done through the stoma hole, and do they have to make other incisions, is the question.
So yes, typically it's laparoscopic, and you may have a couple of laparoscopic sites. If your ostomy was created laparoscopically, they would use the same laparoscopic sites, but a lot of the work is done through the opening of the stoma. And I will tell you this, many of the surgeons that do these reversals They don't actually close the skin level because it's considered a dirty area. You've had a stoma there. They'll close and suture the lower levels, the muscular, obviously the intestinal portion, the muscular portion, and then the subcutaneous tissue. But they do leave that skin open. And so, it may be round like your stoma. We just cover that with a dry dressing because we want any bacteria that may have accumulated in that area to work its way out. So that would just require a dry dressing change every day or as often as you need to. But other than that, that closes, you will have a bit of a scar there, but it's important that we leave it open so that you don't develop an infection.
Okay, so we had another comment. It's actually, she put it in chat. That's okay. We're just going to address it. It said, I had a colostomy on 12/11. Please let me know why my reversal was scheduled 4/7. Doctor started and could not complete due to too much scar tissue. He said I needed to wait 6 months with a question mark. And then also this listener has developed a peristomal hernia. And can this be repaired same time as the takedown?
Okay, so if you're, and I'm going to assume, I should never do that, but I will assume that maybe you had a perforated diverticulitis and you might have had some pretty good infection going on there or an abscess of some kind, which the body takes, aside from having an abscess, the body takes a certain amount of time after a surgery to heal. And that means for the inflammation of surgery to resolve, for the scar tissue that builds to soften. If you wait for that process to finish, the reversal surgery is easier for you, and it's also easier for the surgeon. So if there's still inflammation going on, because maybe you had an abscess from a perforation or something along those lines, it's better to wait and go back. I have seen patients go in for a colostomy reversal, come out with an ileostomy because they do that reversal, but they're fearful that where they hook back together will not heal appropriately and it can break down. And if it breaks down, you end up again with peritonitis, a big infection. You can get sepsis from that. So it's safer to divert until that heals, and then you go back and get the ileostomy reversal. So that is fairly common, but usually it's because there's some type of infection or inflammation still occurring in the body.
Listener said that is what they had. They did have what you suggested. So
okay, perfect. Then, so the second question was about the peristomal hernia. So when they do that reversal and they close that muscle up, that hernia is repaired automatically because everything goes in where that stoma is, and they're going to close the muscle. So that automatically gets repaired.
Okay, so if anybody else has any questions, please take a moment to put them in the Q&A section, or the listener was gracious, said thank you for all that information you just shared, Christine. So if there's any other questions, you can put it in the Q&A section and we can go ahead and get those answered for you. Do you recommend a belt to be worn to prevent hernia prior to takedown?
Prior to takedown, no, unless you're somebody who's using or very active, doing, heavier lifting, or you're really working out. I would request or it is a good idea. I would recommend that you use a hernia belt or a support belt. There are many companies that make them with the opening for your pouch, so that your pouch isn't stuck inside of that. So stool can freely flow into the pouch and not be hindered by that binder. So it's not necessary to wear one, but if you are going to be very active and do strenuous activity, I would recommend you wear one.
Viewer said, thank you so much. I felt lost since I was discharged. This has been so helpful.
Anytime.
Okay, we'll just give it another minute if anybody else has any questions. And then,
Heather, I do understand that depending on where you're at in the country, I find there's a lot of ostomates who go home and don't have support, and they're out there looking online for help in gathering information to help them cope with this. So you found HPFY.
yeah. In addition, the second Tuesday of every month, we do have an ostomy support group that meets. Christine works with me as well at the ostomy support group, and we also get some support from our manufacturing partner. We usually have our representative from Coloplast, and we will have other representatives from other different manufacturers as well to provide insights on the products if you have any questions about products. And that support group is fantastic. So encourage all of our listeners as well to look on our Facebook page and get information about support group, because again, it's just an open share of information, and people have been where you are, and it's very, very helpful. So we have a few more questions. In your experience, first we have someone who said, thank you for the information. My colostomy was a big surprise from sudden diverticulitis, abscesses, sepsis. So it seems like I really need to wait until I am all healed before I get the reversal, which is the answer that that patient needed, which is great. The second question is, in your experience after reversal, do most people go back to living a normal life and never have to worry about it again?
Never have to worry about diverticulitis, or I guess I need a little bit more information. If you have your stoma because you had diverticulitis, the recurrence rate of diverticulitis is very low. It can happen because you can get diverticulitis in any portion of your colon. The most common is the sigmoid colon, which is the lower left side, but it doesn't mean you'd have to have surgery again. Typically, if you develop diverticula, eating a diet high in fiber keeps those diverticular pockets clean so that things don't get stuck in there and cause that infection, which is what causes diverticulitis. So once you're reversed, it's always a good idea to, once you're healed, go to that high fiber diet if diverticulitis was the reason why you needed a stoma.
Yeah, so that patient did say scar tissue, ... and diverticulitis. So that, I hope, answers their question. Another patient or listener said, having maintained your ostomy, what products are available to manage aesthetics of the pouch?
Aesthetics of the pouch, meaning?
Yeah, what are, I think that's what they're at, the ESTHETIS, so aesthetics of the pouch. So maintain your ostomy, what are the products to manage? So if I think perhaps they're asking about the aesthetics, from it popping out or something like that. So
okay, so to me, it sounds like you're looking for something that's not as obvious. Some of the one-piece products look a little bit more lower profile, you know, certain clothing that you're wearing. There's special underwear that you can buy that help with like Ostomy Secrets. I mean, that's one of my favorite places to go. They have all sorts of panties that have pockets in them that hold your pouch and offer support. They have bathing suits for men and women with a pocket in it to hold your pouch and support that. They have the wraps that help minimize the pouching system so it's less noticeable underneath your clothing. If you have a colostomy, if it's a permanent colostomy, there's other things you can do after your ostomy has matured. You know, if you have regular bowel movements and you know when you're typically going to be active, you can use a stoma cap as opposed to a pouching system. So that can minimize for you. There's pouch covers. If you're interested in that, the pouch covers just go right over the pouch itself. And I'll just use this. It's got an elastic piece that goes right around this, but it covers the rest of it. Some of them will have a zipper on the bottom to allow you to empty the pouch. Some of them you would just take the cover off to empty your pouch. Am I answering your question, I guess, is what I need to know.
They didn't respond. Let's give them a second. I'm thinking you did because they didn't respond. And let me see here. Yes. What was that website again?
Oh, Ostomy Secrets.
I can put it in the chat for you guys if you want.
And I will tell you, I have a number of products from Ostomy Secrets. Their wraps are about $30. They're very well made. If you Google ostomy panties or ostomy wraps or pouch covers or things like that, you will get a whole slew of different websites that have things. There's a lot, like on Etsy, offers a lot of things as well. I'm happy with Ostomy Secrets just because it's very high quality. But there's plenty of other products out there. So there's lots. Just Google them.
This patient says that he's been using the stealth belt.
Yep, a lot of people use the stealth belt. And that comes in it comes in a vertical pouch where your pouch stays in the downward position. And they also make one where you have to turn your pouch sideways. So it's not as wide. And that's fine for a colostomy, but if you have an ileostomy, I would recommend you get the one that faces down. And that has a zipper in the bottom that allows you to empty your pouch. And Velcro's on where the wrap is just elastic. So good product, the stealth belt. They also make swim ones, the stealth belt. They make stoma guards for if you're active, with things that can injure your stoma, like racquetball or tennis or something like that. You might want to consider looking at the stealth belt website.
Okay, I'm going to give just another minute for final questions, and then we're going to wrap up. Christine, do you have for next month's webinar, is there a topic?
Yes, there is. We're going to revisit surviving the summer with the stoma. I know I did one of these last summer. I'm going to add some information. So we're getting closer to the warmer weather. So let's add for that.
That's great. Okay, so if nobody else has any questions, I think that this is a time that we're going to wrap up. Again, we're Health Products for You and shopostomysupplies.com, and we are so happy that you joined us. This content and the recording will be on our YouTube channel. Yes, Christine? Is that correct?
It is. They're a little bit delayed getting onto the YouTube. I'll have to talk to somebody about why they're so delayed getting there. There are a couple already on there, but I'm waiting for someone to our person, Akancha, to notify me when the rest of them are up. Because I do have some people who are looking for those links.
Yep. So to answer the question, no, there won't be anybody. There won't be any names used. All the Q&A and questions are anonymous. So there's never, the only information that's here is the questions themselves. That's why we don't use anyone's name. So there's some question about that. And so we are, so we're just, that's why we use the Q&A option so that we can just answer the questions for people and we can have it be anonymous in nature. So, so with that, we are going to wrap up. Thank you for all of our listeners, for all the people who joined us tonight. Christine, for your extensive information. This is fantastic information and super helpful, I'm sure, for all the patients that were listening tonight. And I look forward to hearing more information and being with all of us.
Thank you, everyone. And thank you, Heather, for hosting.
Okay, everybody have a good evening. Bye-bye.